Thank you, Julie. Thank you, Michigan WIC, for the privilege to be here. How proud WIC must be to have given us Trish McEnroe. So that's a terrific thing. I want to say this at the beginning of each of my presentations because I'm surprised how sometimes I hear somebody in WIC say they didn't know that you are the premier national breastfeeding promotion program. And so I want you to just take that in. And not only are you impact more than half of all mother-baby pairs in the nation, but you serve the mothers and babies that stand to have the greatest benefit from the improved health outcomes from breastfeeding. So thank you for all of you for what you do. So I'm going to talk about, kick things off with some progress we made in Colorado over the past decade that had to do with our supportive hospital policies. I don't have any relevant financial or commercial relationships. So this project that I'm going to open up with began in 2003 when Colorado WIC, along with the Colorado Breastfeeding Coalition and the Colorado State University, decided to survey the hospitals and birthing facilities in Colorado. So at that time there were 55. They got responses from 53. And this was the hospital themselves saying how they're doing with breastfeeding. And I'm not going to go through the answers, but mostly the hospital said, well, we're doing really well with breastfeeding. So then our own Jennifer Delaporte, who was at the time our state breastfeeding coordinator, said, well, isn't that lovely? I wonder what the moms would say if we asked them about their hospital experience, okay? Not just what the hospitals say they do, but what the mothers say they got when they gave birth there. So I think certain questions had just been added to the pregnancy risk assessment monitoring survey. I'm going to put this a little bit closer, although I'm causing trouble. You tell me if you need to send. I'm going to put it more in the middle, so I turn both ways. So they'd asked some questions about the baby-friendly steps and wondered if this impacted breastfeeding outcomes for the mothers, and wondered also if it impacted outcomes by socioeconomic status. So I don't need to go through all of these, but these were in mom language for the baby-friendly steps. So did your baby stay in the same room? Did you breastfeed in the first hour? Did your baby get fed only breast milk? Did you get a gift pack with formula and so forth? So did your baby use a pacifier? So it turned out that 5 of the questions they asked, which I tend to refer to these as, I'll have to ask Trish if that's okay, but I kind of call them the anchor steps of baby-friendly, some of the things that a mother would most remember and know about as opposed to what the hospital policy was. So each one of these separately had a positive impact on breastfeeding duration if the mother experienced that supportive practice. I'll come back in a minute and tell you about what happens if the mother got all 5. Now, we only had 19% of Colorado mothers who did get all 5, but let's look at them one by one. And by the way, this is in a handout that you can download from the website. So I'm a compulsive note taker, so write down if you want to, but also know that just about everything is on the handout. So in each of the graphs I'll show you, the purple line is the breastfeeding duration, 100% of all these mothers that started breastfeeding. And as you know, PRAM's data only goes out to about 4 months, and so how breastfeeding fell off over time. And the purple line is always higher than the orange line, which was the mothers who did not get that supportive practice. So you can look at each graph and say breastfeeding in the first hour enabled mothers to is linked with mothers breastfeeding longer. My baby received only breast milk. That was the most significant one. Mothers breastfed longer. Baby stayed with me in the hospital room, rooming in. Purple line, the more mothers were still breastfeeding as we go out in time. Infant did not use a pacifier in the hospital. If the mother got that supportive practice, it was more likely that she would, more mothers were breastfeeding, like 55% at 4 months were still breastfeeding. If they got that supportive practice, only 46% were still breastfeeding if they did not get that supportive practice. But what was really powerful was, and we'll mention the phone number. The way they worded step 10 was, were you given a phone number to call for help? Did you have any kind of follow-up plan for a breastfeeding problem? So the real difference was noted for the 19% of mothers that got all 5. If you got all 5 supportive practices, look what it did for breastfeeding outcome. At 2 months, 64% of the mothers who got 1, 2, 3, or 4, but not all 5, 64% were still breastfeeding. But if you got all 5, 63% were still breastfeeding 2 months later. So getting all 5 pushed breastfeeding out 2 more months. And the even more striking thing, it's very hard to improve breastfeeding rates with the populations you work with that have so many barriers to breastfeeding. And some of the things that might help among more privileged mothers, the challenges are so daunting in disadvantaged mothers that some of the interventions don't work. But if you look at the mothers, these are the mothers with the high socioeconomic status mothers, and then again, if they got all 5, the same thing happened. If they got all 5, 78% who didn't get all 5 were breastfeeding at 2 months. 78% who did get all 5 steps were still breastfeeding at 4 months. It also pushed breastfeeding out 2 more months. And then the most exciting of all was the Medicaid mothers who have a rapid fall off in breastfeeding duration, but 47% were breastfeeding at 2 months if they got 1, 2, 3, or 4 of the supportive practices. 47% were still breastfeeding at 4 months if they got all 5 of the breastfeeding practices. So this was so exciting that that right away they wrote this up and published it. But again, that whether the income was at, below, or above 85% of the poverty level, the breastfeeding durations were pushed out 2 more months if you got all 5 supportive practices. So they got this published in a journal called Birth, and the whole issue of that journal had been devoted to perinatal care. And I want to just keep coming back to Jennifer Delaporte that really was the impetus behind all of this. And I just want to commend Jennifer, who was, again, our state WIC breastfeeding coordinator, that every time she saw something else to do with this data, she jumped on it and made it happen. I was just a little pawn in that. So they decided we've got to disseminate this to hospitals. Hospitals need to know about the things they can do to make such a powerful difference. And we need prenatal people to prepare mothers for an optimal hospital breastfeeding experience. One of the first things they did was to develop these crib cards that WIC started giving out to all mothers, and they were made available to hospitals upon request. So they were pink and blue, and they took the 5 steps and put them in mom language with about 2 sentences per step. So the moms had these that they could look at prenatally and discuss with WIC and then bring to the hospital. Well, they didn't have any funds right away, and so Jennifer said, look, maybe the coalition could use volunteers to visit hospitals in their community, or maybe there's someone on the coalition that works at a hospital, or maybe somebody has a connection at a hospital. So we're going to empower these volunteers at the coalition to go out and visit some hospitals. So they developed a lovely resource kit with a CD with the data, and they gave them that beautiful printed glossy thing of the article. We don't have to go all the way, but this was a shiny thing with beautiful resources and appendices with the AAP policy statement and the OB policy statement and lots of resources. There were sample policies from Baby Friendly and good things in there. So 8 volunteers, I was one of them, were able to visit 21 hospitals total with this volunteer effort. And people were glad to get the resource kit and glad to get, but I got to be honest, we could have done better. I mean, we had mostly contacts with the lactation people. We couldn't get administrators there. I know the day I met, we got 3 people showed up and the PowerPoint didn't work, and it was disappointing. So it was a good effort, and one of the best things that came out of that was the day that I was trying to explain my experience. I've actually spoken in 48 states over 42 years. That's why I have a long history in breastfeeding promotion, and so, just because I'm old. But so I've been talking about Baby Friendly from the beginning, but if I would speak to an audience in another state and talk about Baby Friendly back in the day, I would get a lot of this, a lot of posturing, a lot of shut down, and there'd be the attitude that, well, we can't do that here. We're special, and you don't know our CEO, or you don't know our doctor, you don't know whatever. But the weird thing was, when I did the few hospitals that I did for this volunteer effort, right away I found the staff turning to one another going, well, we could do that, we could do that. And when I was explaining that to our first hospital-based lactation consultant in Colorado, Carol Anderson turned and said, well, why don't you call it the Can-Do 5, since people are saying we can do that. So that's where the name came from, and it came out of that. So, so anyway, then Jennifer was able to get some funding. I forgot where it's from, but perhaps it's on a slide here. But anyway, she got some funding to do a project, And I was privileged to get to be the consultant on that project. And now we were going to really go at this. And the health department sent out a letter to all the hospitals that hadn't been visited. And it was first come, first served. They're going to get this free training. And I'm going to go all over the state and visit these folks. So I went to like 25 hospitals, maybe 28. The red dots were where we were able to visit hospitals for the volunteer effort. But they were mostly on what we call in Colorado the Front Range, all the major, larger areas. And the blue dots are where I went on my road trip, and I did not have this sports car. But anyway, I went to all remote areas of the state and really was able to, it was one of the most, it was just a very powerful experience for me. I got to, out in the agricultural area and on the western slope and out in some very low-income areas, and it was really quite inspiring. And let me just go back and say that I made a huge effort that I will do this talk whenever you think people will come. If you need me to do 2 shifts for nurses, I'll do that. If you need me to do the docs at their 7 o'clock perinatal meeting once a month, I'll do that. I'll do something at noon. I'll do something at night. You tell me what they'll come to, and I'll show up and do it. And but the comments, just to give you some, was very, very inspiring. Thank you for bringing our partners together. Jennifer got it that the hospitals can't make the change. I'll never forget one of my first visits, having a hospital nurse say, we know this stuff. We want to do it. But if the mother doesn't come knowing what's good for her, she thinks she's coming to get a rest and send the baby to the nursery. You've got to prepare her. We cannot implement these things without you having the mom get that mindset. So they're excited. I'm going to put it in my childbirth class. We're going to start educating this in labor and delivery. I'm going to do more skin to skin. We're committed. We just need more tools, and thanks for giving us the tools. I mean, somebody was like, hey, our supervisor supports the block party, and it's getting unbearable. It's impossible to get an early feed. Thanks for saying this in front of our supervisor, and that we're going to have quiet time. We're going to think twice about supplementing and what kind of volume to supplement. We want to remove the gift bags. A couple hospitals said, we're not going to just do 5. We're going to go for the whole baby friendly. They were really excited. A nurse-family partnership. We're going to use this every day. I'm going to start a follow-up program. We're going to start a local breastfeeding task force, a mother support group. I mean, people were on fire. And one of the big things, I think, was that we were able to get in one room admin, labor and delivery nurses, WIC partners, visiting nurse partners, all kinds of different community partners, Head Start, lots of people getting it that we're all in this together. What's my piece of the breastfeeding puzzle? And one of the other things that I think helped was that, everybody's proud of what they do, and they should be proud of what they do, and they should have somebody celebrate it. And so I'd say, oh, thanks for showing me your new unit. Oh, look at this, you do a pump rental. Oh, look at this, you have a support group. Let me go to your support group. But to praise what they're doing to inspire people to want to do even more. So the groups vary depending on the size of the place. This was one that really inspired me because it was a 2-hospital town that kind of competed a little bit. And that one of these folks, Jerry Davis, was one of the best-known lactation consultants in the whole southern part of the state. But those 2 hospitals came together and decided to both agree to get rid of the bags together so that they wouldn't be competing. Well, the mother gets a gift at this hospital, and she doesn't get a gift at this hospital. And so they both, presented about that. So we'd bring in the local people. And so anyway, it was very, very inspiring. Well, when we finished that was 2009. I think we did a few more into 2010. And by 2011, I don't know whether some hospitals asked Jennifer Delaporte or whether she just got the idea, folks are wanting to be acknowledged if they have the 5 steps, okay? So this was nothing like a baby-friendly site visit. This was like, submit your policies, and if we see that you do have all 5 steps, properly written, that cover, correctly, Jennifer came up with the name for a Breastfeeding Excellence Starts Today award that would be given out by the health department. So the first one was given out in 2011. I think that was at a perinatal care council meeting held at the health department. And then they gave some more awards in 2012 at our first statewide hospital, summit. And then gave some more out in 2013. And then at that point, Jennifer really got it that we're not fooling around anymore. The next award's going to be Baby Friendly, given out by Baby Friendly USA. But by the time, by 2013, 77% of Colorado hospitals had policies for the Can Do 5 policies. And we switched the focus. But, this wonderful Yvonne came all the way across the state to get her award from, one of the furthest away. This is Jennifer Delaporte that really just kept inventing the next step and the next step and the next step. Well, I knew from a long time about the California model policies. I was aware that Texas already had their 10-step program. Very shortly after this happened, I spoke in Arizona at a WIC conference, and they were all on board with it. I mean, they were one of the fastest ones to come up with their own 5 steps, the Arizona baby steps with their little logo. I spoke in Missouri, and Missouri is the Show Me state, and they right away came up with the Missouri Show Me 5, and they started pushing this largely through WIC. Spoke in Kansas, and they came up with the High Five for Mom and Baby, with even had them high fiving it, and so where else? Maine, Breastfeed Me, because ME is the abbreviation for Maine. And I think some states just said, well, we'll just do the Colorado Can Do 5. So they didn't need their own state name on it. So I mentioned, we then had the first, with Jennifer's idea, seeing other hospitals having other states having a hospital summit. And Jennifer arranged for us to have the first summit. Weren't you there at that one? I think Trish came for that. One of the things, let me just give you an example of what a statewide summit can do. One of the breakout sessions I went to was life-changing. It was a nurse from North Colorado Medical Center, and she presented their experience with skin-to-skin after C-section. When I was speaking at all these hospitals, we thought we were really cutting edge when we said a C-section mom could have cheek-to-cheek. Because back in 2009, skin-to-skin was just, no one was talking very much about doing that, maybe in other countries. So this nurse talked about how a couple came in, and their baby had a non-viable birth defect. The baby was going to die soon after birth. It turned out the nurse manager's master's thesis was on palliative care. And this family had asked, since our baby, we don't know how long to live, minutes or hours, can I go, and it was C-section birth, can I have immediate skin-to-skin? And that nurse said, well, I guess for this special case, talk about the, what is it, Plan, Study, Do Act, or Plan, Do, Study Act, yeah. Plan, Do, Study Act, or no, but anyway, Trish knows how to do it. So they did it. They made it happen for that one special case. And it was so moving for everyone involved that they all turned and looked at each other and said, why can't we give this to everybody? They immediately started doing it. And so we invited her to come to our Lactation Journal Club and present it there. And next thing you know, other hospitals were saying, well, gosh, if they can do it, we can do it. And then it's just like everybody's doing it now. So anyway, then the next thing, she started in 2013, got some funding for Colorado Baby Friendly Hospital Collaborative. Boy, was that a big change in Colorado with CDC and MCH grants. The collaborative has been phenomenal. At the time that was started in 2013, we only had 3 previously designated hospitals. One opened Baby Friendly, so they didn't have to, change any attitudes. You just, if you want to work here, we're opening Baby Friendly. And 2 others were within the same hospital system. Just since 2013, we have 7 more designated hospitals, and we have 13 on the pathway. We have improved our MPINC score up to 7th in the nation right now, just from the work of the collaborative, I think. And one of the things that's most, here's some evidence. This is breastfeeding at hospital discharge. These are hospitals that are not in the collaborative or baby friendly. These are the collaborative hospitals with much higher, breastfeeding rates, and then these are the baby-friendly designated hospital discharge breastfeeding rates from 2012 to 2015. I think what's even more gratifying is that the hospitals in the collaborative serves a much more diverse population. So again, when those hospitals all get certified, we were reaching the mothers for whom breastfeeding can have the most important improved health outcomes. So I want you to know that Stacy Miller, who is now our new breastfeeding specialist for the state, started, I think, in 2014. She made it clear that, this is grant-funded stuff. You guys have right to access all of the resources at the collaborative website and are free to contact her for any other resources or information you want to get from Stacy. And in my remaining, I hope I have 1 or 2 minutes, I just want to say a word about one other unique thing in Colorado, and I'm privileged to have been part of this, is the Colorado Lactation Journal Club. So in 1985, we opened, I think we were the second, if you don't go back to Margaret Mead, the second breastfeeding center right after, a couple months after Audrey Naylor started WellStart. So we opened the lactation program at St. Luke's Hospital. We had NICU support for moms, a little March of Dimes grant. We had well baby support. We had prenatal classes, breast pump rentals. We're talking 1985. We had the Mother's Milk Bank, which we had just founded 2 years earlier. And we were doing research, and we were doing quarterly conferences. And and people started calling us from all over. And I said to myself, well, if people are calling us and think we're the expert, we better have a journal club so we can stay up with the literature. So we started a little journal club and said, well, if we're going to have a journal club, let's invite a few people. So we invited some people. And now 32 years later, we've still got Lactation Journal Club going on in Colorado. We webinar it so people can come from elsewhere. We've gone through different kind of sponsors to handle the registration, but right now Mother's Milk Bank, which is part of Rocky Mountain Children's Health Foundation, does the registration. I still do the agenda and present at each one and pick topics. And I think one of the reasons it's lasted was, well, first of all, I'm excited we have such a diverse group. We even make it part of a med student nutrition elective, so we always have some med students coming through. We have hospital-based lactation consultants. We have WIC. We have Nurse-Family Partnership. We have a handful of physicians. Mother's Milk Bank is involved, office nurses, all kinds of folks. And some of these people have come for decades, not years, but decades. One is now in the retirement home. And it's fun. I mean, we do all kinds of topics, a new protocol, some new article. I happen to like controversy. I like things that, we all like things that confirm our view of the world, but I like sometimes to challenge us. And some of our members are willing to present, others don't want to present. We've had guest speakers. Who's our Peter Hartman. I heard he was in America. It was our 20th anniversary, and I've known him a long time. And he actually came and presented at our journal club. We had Paula Meyer, we had all kinds of people. We sometimes like the one we just did was healing breastfeeding grief. It's sort of the elephant in the room that nobody talks about, all the people that had a disappointing breastfeeding experience after we've, made them feel like, boy, to get an A in motherhood, you better do this, and formulas, the risks of formula feeding, and then what do you do when you have the nightmare experience? And so, and what do you do when you need to heal your own grief from, not being able to give the mom the experience you wanted? We do charge a modest fee, and we get CERPs and we get CEUs, and people just love networking with their Colorado lactation community and seeing the folks from a partner hospital in another part of the state. And they still bring food. We started out, they volunteered to bring food. And so I'm very proud of that. And just like I said, the networking thing, and that's the one we just did last Wednesday on the healing breastfeeding grief and some other topics. So I hope I stayed on time. I didn't look. And thank you very, very much for the privilege of sharing this with you.
Yes, escape. Yep. So I'm just not going to take the time to mic up. I'll just use the microphone right here. It's always amazing to share the stage with Dr. Neifert. She's incredible and inspiring and has always been a great mentor to me. So it's an honor to be here with you. Also to share the panel with Dr. Schreck, who has just been doing incredible work in the state of Michigan. So let me thank the Michigan State WIC program for including me here. As you perhaps noticed in my bio, my background is with the WIC program, and so I'm always most at home when I'm with a WIC audience. So I'm delighted to be here with you, and thank you for including me in this important event. So piggybacking on what the fabulous foundation that Dr. Neifert laid for me, I just want to address a quick question that I'm often asked about. She talked a lot about great state programs that she ran or helped inspire and help support. And as the Baby Friendly Hospital Initiative, we're asked often, well, what do you think about those state programs? So I just want to say I think they're great. And we really work collaboratively with as many of those programs as we can. Any effort that states are doing to help improve maternity care practices really help us all with meeting our objectives. So first and foremost, we're all mission-driven people wanting to make sure that mothers and babies get the most outstanding care possible. We hope that folks will eventually join our program, but we're supportive of all hospitals making practice improvement. And thank you, Dr. Neifert, for laying this fabulous foundation, because it's that early work of some of those great state programs that really led hospitals to join the Baby Friendly Hospital Initiative. So today we're just going to talk a little bit about what is the Baby Friendly Hospital Initiative, the advantages of becoming baby friendly designated, the 10 steps to successful breastfeeding, and the process for becoming baby friendly. So I took a lot of notes in our ethics discussion this morning, so I just want to have my disclosures that I am an employee of Baby Friendly USA, and that has led me to present a very biased set of information today. So I'm going to tell you how great the Baby Friendly Hospital Initiative is. But going back on this slide, we are not an organization supported by any organizations or companies that violate the International Code of Marketing of Breast Milk Substitutes. We're strict adherers to that code. So let's start off by talking about what is the Baby Friendly Hospital Initiative. We're an accreditation program for maternity facilities that have created an optimal environment for appropriate infant nutrition and mother-baby bonding. We used to exclusively say we were all about breastfeeding, but there are some circumstances that when moms wouldn't be advised to breastfeed, and so we've sort of modified our language there because we are providing support to all mothers. We believe breastfeeding is optimal infant nutrition, and we want to create an environment for that supports the greatest chances for breastfeeding success, but we also create a supportive environment for formula feeding mothers as well. The Baby Friendly Hospital Initiative is an international program. It is co-administered by the World Health Organization and UNICEF, and then it is run in conjunction with national authorities in each of the countries. So in the United States, Baby Friendly USA is the national authority for the Baby Friendly Hospital Initiative. In other countries, it's run by UNICEF, or it's run by professional associations, again, other places also use the model of a not-for-profit organization designed for the purpose. So why should a hospital pursue designation as opposed to just practicing the 10 steps? We often hear that's an option for hospitals, and so why would you want to go about going through the whole baby-friendly process? So first of all, accreditation is a status that's awarded to organizations that demonstrate compliance with the accreditor's standards. So in the case of the Baby Friendly Hospital Initiative, we have set a specific set of standards that hospitals need to meet, and then we go in and send a team that hasn't had any prior relationship with that hospital. We go in and evaluate them on those set criteria so that the hospital then can say there's been an external review of their practices and that they are certified as providing the 10 steps to successful breastfeeding in accordance with the evidence and with the standards set by Baby Friendly USA. So it's a marketable term, and there's an advantage. We also, some hospitals don't think this is an advantage. I think it is. We hold them accountable for maintaining those standards over the designation period, and so there's auditing that hospitals must do and data that must be submitted to us on an annual basis to assure that the standards remain in place. We don't just care about the day we are visiting a hospital, we care about the care for the longer haul. So that's one of the advantages of designation. So if you're a facility, why should you work to achieve baby-friendly designation? Why do we care in this room, why are we trying to help hospitals work to achieve baby-friendly designation? So the first answer I would give you is national policy. Many of you, I'm sure, have heard about the Healthy People 2020 goals. These are a set of health objectives that have been set by the U.S. Department of Health and Human Services to, for hopes that specific populations will achieve so that we can be a healthier America. So there are maternal and child health goals that impact WIC. There are some specific goals that impact breastfeeding. And WIC, of course, is a major role player in this area. But our country hopes that at least, and this is, I can't help but make fun of this, 81.9% of women will initiate breastfeeding. So, sorry, I don't know who came up with these numbers, but they are kind of, they'd always make me chuckle. But we're hoping that we will see the majority of women initiate breastfeeding. We hope that by 6 months, 60% of women will be continuing breastfeeding and 34.1% at 1 year. We also, as a nation, have some goals for exclusivity at 3 and 6 months. And so the WIC program is a very key player in helping this nation achieve these Healthy People goals. And we consider the Baby Friendly Hospital Initiative to be an important player in helping this nation achieve these goals. Our role is to help get breastfeeding off to a good start. We can't have continuation if we don't start it off right. So we hope that we're starting things off right and handing the baton over to you to continue the great work. So that's what these goals are about. The nation also has set some goals for the number of babies being born in hospitals that provide recommended care for lactating mothers and babies. When this goal was set, we were at a baseline of 2.9% of the babies in the United States were born in baby-friendly designated hospitals. They were hoping that by the year 2020, we would be at 8.1%. And I'm happy to tell you that we are at 20.6% of births. So we're really excited. So, thanks. So I hope you know that round of applause is for all of us here in this room, because it's all of us working together that have helped us achieve that goal. And it's amazing what we can all accomplish when we do work together. So thank you. So excited about that. So another Healthy People 2020 goal that I think very significantly is impacted by the Baby Friendly Hospital Initiative is reduce the percentage of breastfed infants who receive formula before 2 days of age. So when we were looking at a baseline of nearly a quarter of all breastfed babies were being supplemented in the hospital, we hope to get that down to 14%. By the year 2020. I think the last I peeked at it, I think we're at about 19% at this point. So we're making some progress, but we still have a lot of work to do. Other reasons why hospitals would want to join the Baby Friendly Hospital Initiative and work to improve their practices is that they've been called upon at the highest levels of our government to do so. So in 2011, Surgeon General Regina Benjamin issued a call to action to support breastfeeding. And action number 7 is to ensure that maternity care practices throughout the United States are fully supportive of breastfeeding, accelerate the implementation of the Baby Friendly Hospital Initiative. The CDC has been calling for action on improving maternity care practices through their vital signs, through their MPINC reports. Are any of you familiar with the MPINC survey? Let me do a quick explanation of this. MPINC stands for Maternity Practices in Infant Nutrition and Care. It's a biannual survey that's sent out to every hospital in the United States that has a registered maternity bed, and the hospitals are surveyed on their implementation of essentially the 10 steps to successful breastfeeding. At the completion of the survey, the CDC gathers the data, summarizes it, scores it, and they give back to each individual hospital a benchmark report telling them how they've done in helping the nation reach its health goals for supporting breastfeeding women. So it's a very powerful tool and something you can work with your hospitals to help them with identifying the need for improving maternity care practices to support breastfeeding. So moving on, those are some of the reasons why we should work to become baby-friendly designated, and let's see who's doing it. So internationally, they stopped gathering data at around the year 2006. So we know there's at least 20,000 hospitals globally that are baby-friendly designated. But here in the United States, We currently have 420 designated hospitals. We're at 20.6% of births, which represents about 821,000 births each year are happening in baby-friendly designated hospitals. So for me, the perspective is when I joined the organization in November of 2009, we had 80 designated hospitals, and we had 70 hospitals working towards designation. So it's the collective work of all of you in this room, the work of Dr. Neifert, the work of Dr. Schreck, the work of the Kellogg Foundation, the work of CDC that have really worked to help drum up business and help expand and improve practices across the country. So I'm excited about the 420 designated hospitals that we have in this country, but I'm equally excited by the 704 hospitals that are working towards designation, some of them here in this state. And we'll look at your state data in just a moment. And just as perspective, there's about 3,100 hospitals with registered birthing beds in the United States. So we're engaged with about a third of the hospitals in this country are showing interest in improving practices. So looking at the state of Michigan, what's going on here? So I'm excited that you have 12 baby-friendly designated hospitals, again, thanks to the fabulous work of Dr. Schreck, who's been really leading the charge here in this state. It represents 31.9% of Michigan births, and it's about 29,750 births per year in the state of Michigan are happening in baby-friendly designated hospitals. So that's really exciting. You have an additional 17 hospitals working towards designation, and I believe you have, when I looked at the chart that I looked at, and I'm not sure if it included all of the hospitals in this state, there were about 72 to 75 hospitals with registered birthing beds in this state, according to the data I was looking at. And it was MPINC data, so if any of your hospitals didn't participate in the MPINC survey, then they're missing from that number. So it may be a little bit higher, but it's at least 72 hospitals with birthing beds. So you've got a good number of your hospitals engaged in the program. We have some work to do still, as we do around the country. So how do you work to become baby-friendly designated? We have posted our guidelines and evaluation criteria online. They're on our website. So if you go to babyfriendlyusa.org, and on the home page, you'll see a quick jump button called Guidelines and Criteria. Click on that, and that will take you to the page where you can download the document that's shown on the screen. And so it's free of charge. Anyone can look at it. Anyone can use it. Hospitals can use it to work to improve their practices even prior to joining into our program. One of the things I'm often asked about, and we'll talk about this in a minute, it's what's the difference between a guideline and a standard and an evaluation criteria. A guideline represents the standard of care that we hope to see hospitals strive to achieve for all patients. The criteria for evaluation are the minimum passing grades a hospital must achieve in order to become baby-friendly designated. So I'll give you an example of that in a couple of slides. But the guidelines and evaluation criteria are based on the 10 steps to successful breastfeeding. So they are organized in the order of the 10 steps to successful breastfeeding. Every step has at least one guideline, and every guideline has at least one criterion for evaluation. Just as I said, I would give you an example of kind of the standard of care versus the minimum passing grade. You will see language in the guidelines that will say all mothers will receive immediate skin-to-skin following birth. And then the criterion for evaluation would say at least 80% of mothers will report that they receive that care. So there is a gap. There is some room for some moms not to receive the care practices that we recommend for whatever reason. Sometimes the mother doesn't want to receive the care practices. Sometimes the hospital's unable to deliver them. So there is a little bit of room for breathing from the hospital standpoint. Some of the principles behind the Baby Friendly Hospital Initiative are that well-constructed, comprehensive policies effectively guide staff to deliver evidence-based care, that well-trained staff are able to effectively practice evidence-based care, and that monitoring of practice is required to assure adherence to policy and evidence. So you'll see these fundamental principles woven throughout our program, and hospitals are very familiar with them and very familiar with the impact of those principles. When you read through our guidelines and evaluation criteria, you will realize that they're very broadly worded. We often hear from hospitals, will you just tell us what to do? Like, can't you just be more clear? Tell us exactly how you want us to implement something. And our response is we want to empower hospitals to be able to take a look at the guidelines and evaluation criteria, look at the outcomes we expect them to achieve, and then be creative and use their own resources to work to achieve them. We don't want to be so prescriptive in telling people how to do it. The other reality is that these guidelines and evaluation criteria have to be successfully implemented in large urban areas such as New York City. They also need to be able to work in small, very rural areas such as your Upper Peninsula, Northern Alaska. So they really have to be broad enough so that they are elastic enough to be able to be implemented all around the country. So we say to facilities that your challenge is to review our guidelines and evaluation criteria, consider the very specific facility circumstances and how to implement. You have to think about how you're going to implement within the guidelines of within the context of your own resources, your staffing, your plant, your budget, your facility circumstances. So you may hear some feedback as you're working with hospitals. That's sort of our thinking on the guidelines. So the process that hospitals go through to work to achieve the baby-friendly designation is a program that we call the 4D pathway. When the Baby-Friendly Hospital Initiative first rolled out, we used to just give hospitals our guidelines and evaluation criteria and say, go to it, implement them, and call us if you have any questions. What we found is that hospitals got really overwhelmed with the amount of quality improvement projects they had to engage in. So if you were in Dr. Schreck's presentation this morning, I believe she mentioned 80 quality improvement projects that we would impose on a hospital. So in fact, the 10 steps to successful breastfeeding is a bit of a misnomer. It's really more like 79 or 80 steps, but it just isn't quite so catchy in the marketing scene, so 10 is good, and we just bunch a whole bunch of them all together. No. There's a lot of practice change that we're asking hospitals to take on. And so the 4D pathway was designed in order to help hospitals organize the work and think about ways they could implement it in a more manageable fashion. So it starts off in the bottom of the screen where you'll see the first of the Ds is the discovery phase, and that's where hospitals enter our program. This is where it's called discovery because this is the phase where hospitals learn about the initiative. There's no fee to them to join the discovery phase. They get a toolkit in each of the phases, and the toolkit that a hospital receives in the discovery phase is just basic information about the Baby-Friendly Hospital Initiative and the International Code of Marketing of Breast Milk Substitutes, a PowerPoint presentation to help them build support for the initiative within their facility, and they get a data sheet to begin to, and a self-appraisal tool where they can begin to evaluate really where are they with the implementation of the 10 steps to successful breastfeeding. Once they're really ready to get serious about moving forward with some practice changes, they do enter into the development phase. There is a fee to Baby-Friendly USA to move forward, and in the spirit of transparency, that is how my organization is supported by the fees paid to us by hospitals going through our program. So in the development phase, we see their primary responsibility at the hospital is to develop plans to help them think through the implementation of the 10 steps to successful breastfeeding. So first they develop a multidisciplinary or interdisciplinary baby-friendly task force or committee. They develop a work plan that helps them think through how they're going to implement the 10 steps. They develop at least a draft of a hospital feeding policy where breastfeeding is the default that helps drive the implementation of the 10 steps to successful breastfeeding. They develop their staff training plan, their patient education plans, and their data collection plans. These plans are all bundled up and they're submitted to my office, and I have a team of IBCLC RNs that review all of the plans and provide feedback to hospitals on whether or not the plans or the infant feeding policy are driving the hospital towards compliance with our guidelines and evaluation criteria. The purpose of the review of our plans is not to approve the plans, but when I first joined the Baby Friendly Hospital Initiative, some of our early assessments were with hospitals that had been working 5 or 10 years on implementing the initiative. We'd get out there, we had had no prior conversations with hospitals, and sometimes they had been so off the mark after many, many years of work. We really felt that we needed to do something to have early conversations between our staff and the hospital so that we could drive them towards success. So if they were going off mark, we could catch it early and redirect them back to the guidelines and evaluation criteria and point to areas for where they may be missing. So that's really the whole purpose of the development phase. It's making sure the hospitals understand their requirements and that we are able to effectively guide them. As they move into the dissemination phase, that's where they roll out those plans. We have very little role with them, but we provide the hospitals with a series of audit tools for which they can evaluate their own practices and see how well they're doing with implementing our standards. And then when they're ready and they think they're getting ready for the on-site assessment, they transition into the designation phase, and that's when we come on board for the on-site review. So as they're in the designation phase, they invite us to send a survey team out to evaluate them, and they undergo the on-site assessment, which consists of us conducting quantitative and qualitative interviews with the hospital CEO, the nurse administrator. These titles vary from hospital to hospital, so we do with the senior nursing staff, the senior medical staff, senior administration, the purchasing agent, mother-baby unit, prenatal, et cetera, all the relevant areas of the hospital that are impacted by the 10 steps to successful breastfeeding. We also interview a variety of key informants, such as healthcare providers, nurses, all shifts, pregnant women, mothers with both types of delivery, mothers who've had babies in the NICU. We examine a whole variety of documents, including the infant feeding policy, patient education materials, training information that's used with staff. We're always looking for the evidence, making sure it's current, it's up to date, it's accurate, and it's free from commercial interests. We conduct random observations throughout the facility. We look for visible signs of infant feeding messages. We look for mother's comfort with breastfeeding. We look for staff comfort with teaching breastfeeding. We look for where the babies are. We gather all of our data. We compile it into a report. The report is then sent into our headquarters in Albany, New York. I have a staff member that reviews and blinds the reports, and we send it off to an external review board, which is a group of maternal and child health experts. They're names of people you would all know, but we don't disclose those names because we don't want them lobbied. But they review the reports, and they vote whether or not to designate or to not designate. If a facility does not pass on its first assessment, the ERB will make a decision as to what the remedy needs to be. Sometimes the remedy is we just need additional data. Sometimes we have to have a revisit. We typically only revisit on the failed steps. And so most facilities do pass on their second revisit. And then only after they've received written notification from us may they use the term baby friendly. So I'm getting near the end of my time, but I just want to touch on one other topic, and that's the safety of practices. And I'm going to talk about this a little bit more in my session in the next half an hour, but there is a new page on our website that's focusing in on the safety of baby-friendly practices. I know that's been a topic of conversation in popular media, so we're going to keep posting information to this web page or creating new web pages. So as you're looking for our points, our thoughts on certain topics, please visit our website because there are other things. We're constantly posting updated information. So things that WIC can do, just really quickly, and we'll elaborate on this more in the next session. You can work with hospitals to co-train. I know WIC is doing a lot of breastfeeding training Some of my best trainings in the WIC program when I was director of the WIC Training Center were when we combined hospital and WIC staff together, and we realized how well we were all working with families and how committed we all were to breastfeeding, and knew how we could collaborate. Your role with Step 3 education is so important, and your role with Step 10 postpartum support is also very essential. So thank you for the amazing work you do, and delighted to be here with you today. So, I mean,
Thank you. I'm very honored to be part of this panel. I follow the work of my two panel mates very closely, and they're big inspirations to me. So this is a great honor for me to be part of this panel. I am Dr. Paula Schreck. I'm a pediatrician and a lactation consultant. Happy to be with you here today. These are my disclosures. All of these entities are also WHO code compliant. I would also like to warn you that I also am biased toward baby-friendly. I'd like to start my story at my home hospital. On the easternmost border of Detroit, St. John Hospital and Medical Center serves the diverse population of Detroit. And for those of you that attended my session earlier, I wanted to give attendees an idea of how my hospital came to appreciate the benefits of quality-based work. So I'm going to tell you a little bit about how the work at my hospital evolved. In 2004, after hanging out informally with lactation consultants for a couple of years, I lobbied to be given the title of Medical Director of Breastfeeding Support Services, a title for which I had no competition and it was unpaid. So I successfully got the title, and what it allowed me to do was go in front of provider groups like the Department of Anesthesia, and help guide policy and prevent those groups from getting in the way of breastfeeding policy. And so having the title actually really helped with that, instead of having to go in front of the Department of Anesthesia and say, I'm Paula Schreck, I'm just really like breastfeeding. You know, I want to tell you something about breastfeeding. So that's why I sought out that title. But I really felt it was my responsibility with that title to move our outcomes forward, always really focus on outcomes. And our breastfeeding initiation rate at our institution at that time in 2004 was 55%, which was significantly lower than the state level at that time, which was about 70%. So we responded by building up our inpatient lactation service from 4 days a week 2 lactation consultants to 6 days a week 7 lactation consultants. So we thought we probably had one of the largest lactation programs in the state. And we revisited our breastfeeding initiation rate and found that it was exactly the same at 50 to 55%. So in 2008, we created the outpatient breastfeeding clinic. At the time, it was the first physician-led breastfeeding clinic in the state. Now, as was mentioned in my bio, we have 2 other sites in St. John Providence, and there is also an excellent breastfeeding clinic at St. Joseph Mercy in Ann Arbor. I created the clinic because I thought, well, if mothers believe that there's support afterward for breastfeeding problems and that it's accessible to all insurances, and we can really aggressively help mothers with a comprehensive breastfeeding solution for such complicated problems as pain and low milk supply. I could write prescriptions and for antibiotics and galactagogues, that perhaps they would be more willing to adopt breastfeeding or initiate breastfeeding because they had kind of this additional layer of safety net. So the clinic is still running today. It's very popular. We increased from a half day every other week to 2 full days a week. Patient satisfaction is very high, but when we studied the clinic, we found that not only did our overall initiation rate not increase in our hospital, but the continuation rate for the mothers that attended the clinic didn't improve. Probably because the mothers that were coming to the clinic were a self-selected population of women that already had a problem and had a higher chance of failure, but it wasn't the panacea that we had hoped for. In addition, there was a disparity in the patient demographic that accessed my clinic. Although the Medicaid population of my birthing center makes up 55% of the deliveries, the population that would seek out my clinic was only 5% of that population was Medicaid. So I wasn't really reaching the at-risk mothers in my community who needed the support. So in 2011, we took a more holistic approach, and we jumped on the baby-friendly pathway, and we embraced the logic model that Trish showed in her presentation, which I think is one of the best logic models on the market out there. It's very easy to use and very inspiring. And we really stopped focusing on people, on it was a more holistic approach. We focused on quality. We didn't focus on grandiose policies. Although a feeding policy is required, in order to implement baby-friendly, it's really about improving process, not blaming the neonatologist or the provider group or the one nurse or the one manager, but looking forward and improving the process for all, one patient, one nurse, one shift at a time. And when we took that approach, everything changed. And we were successful in our endeavors, and we were the first baby-friendly hospital in the city of Detroit and the second in Michigan. And we're proud that we're a baby-friendly hospital in an urban center because that is less common. And we finally saw a bump in our outcomes. So this graph is the data from our study that was recently published in the April edition of Breastfeeding Medicine. And it shows that our breastfeeding, this is the population that attends our hospital-owned prenatal clinic, so it's 100% Medicaid. And with our baby-friendly practices, we were able to improve breastfeeding initiation from 45% to over 65%. And our overall breastfeeding rate finally moved from 55% up to 75 to 80%. So we still have some work to do because we still have a gap, but it's definitely closing. And baby-friendly is contagious. So once we accomplish baby-friendly at our institution, the other 3 large system hospitals in our area, in the St. John Providence area, also jumped on the baby-friendly pathway through their participation in Best Bed Beginnings. And so now we have 9,000 births in Southeast Michigan and over 1,800 prenatal patients that are under our baby-friendly umbrella. And it was contagious within our urban center as well. In 2014, after our baby-friendly designation, my hospital threw a party for the baby-friendly designation. And some of you here were invited and present. And we invited 2 VIPs. I invited Michelle Obama. She declined. She was busy. And I invited the mayor of Detroit. And the mayor of Detroit at the time, Mayor Duggan, was a new mayor. He was relatively high profile. He had been on Jimmy Kimmel. And he had also been the CEO, very high profile, charismatic CEO of the DMC, which was another large hospital center in Detroit that owned 2 of the remaining 3 hospitals in the city. And my CEO at the time said, good luck with that. We're not really friends. I don't think he's going to come. But he did. He actually came for 15 minutes. He said that he left like a labor dispute negotiation with the police department and the city. He broke away from the negotiations to come. He came with a full entourage, which was very exciting. He said a few words. He grabbed a mini hot dog and he was gone. But it was a moment in Detroit where the other hospital systems really got the message, because he said it, that everyone else has to do this. This is the right thing to do. We have to applaud this. And we support the other hospitals. And within 2 years, I can now proudly say that the other 3 hospitals are all on the baby-friendly pathway. Yeah, so the whole city of Detroit is on the baby-friendly pathway. So there's certainly a lot of other things that we all can be proud of in our state. And what's also unique about the state of Michigan is that a lot of these statewide initiatives are being led by State of Michigan WIC and your visionary leadership. It started out with 5 pilots, and the programs have grown to encompass statewide initiatives in addition to initiatives in 2 key communities, Detroit and Flint. The most recent large-scale initiative in the state was the Michigan WIC statewide initiative phase 1. And that initiative really focused on hospitals. And we sent out a series of carefully designed hospital leadership and hospital staff surveys. There's about 83 birthing centers in the state of Michigan, and 50 of those birthing centers participated in our survey. And in particular, I want to report out, for the purposes of this session, the results of the leadership survey, which showed that hospital leaders, and these were nurse managers, nurse directors, vice presidents, were very much engaged in quality improvement and moving outcomes forward in our state. And in particular, they were interested in staff education, provider engagement, and patient preparedness. These are all things that we're very much interested in here at this conference. They were also very interested in community engagement and engagement in quality improvement. These surveys were also sent out to 922 staff members, nursing staff, and I reported out the results in more detail of the staff survey, but for the purposes of, in my previous breakout presentation, but for the purpose of this room, I wanted to tell you that we asked nursing staff, were they interested in participating in quality improvement? These are the staff that work in the hospital. And the overwhelming majority of nursing staff were interested in quality improvement work, which is, in my mind, code for baby-friendly. So I wanted to illustrate with this narrative the huge amount of interest at the hospital level at moving forward as a state. I wanted to give a shout out to Michigan Breastfeeding Network. Julie Lothamer and I co-chair the Michigan Breastfeeding Network. We have other board members in the audience and project members and staff, because there's a lot of crossover between all of our initiatives. And I wanted to highlight our Flint project called the Flint 310 Connect. The name 310 is inspired by the baby-friendly 10 steps to successful breastfeeding, with step 3 and step 10. This is a collective impact project. So by that, I mean that it's not just the hospital, it's not just the community, it's all stakeholders in the community working together in a comprehensive program to provide a consistent message. So we have home visitors, we have Head Start, we have all 3 hospitals engaged, with 1 hospital joining baby-friendly, the baby-friendly pathway because of the initiative already, and the 2 other hospitals have it part of their strategic plan. So it's a great, I call it our test tube baby, because it's a community that needed support, because it was one of the few communities where the breastfeeding initiation rate had decreased over the last 2 years. And we know why, because of the environmental crisis and disaster in the area. So the community is embracing our efforts, and we're having a very high turnout at our events. And actually next, in a week and a half or less, we have a citywide training for home visitors where we've exceeded our attendance expectations. And the home visitors will get education in preparing mothers for the hospital using the baby-friendly curriculum and the baby-friendly guidelines as the gold standard. So what could we do with this leadership survey? Let's jump back to that, where we had such a high interest in quality improvement. Well, we were inspired by a mini grant that at the same time was released by our health department. We have a breastfeeding coordinator now in the state, Margie Cyril. Margie, are you in the room? Right, Margie right there. That's great, thank you. Margie has really brought a lot of energy to breastfeeding at the hospital level, at the community level, and even at the individual level for people like me that like innovative programs. And Margie's department released a series of grants that for hospitals that were interested in moving forward in a baby-friendly direction. The grant was very flexible. It was not requiring enrollment yet in baby-friendly, but it was using baby-friendly as the gold standard. That was very, very important to me, and I was privy to discussions about the potential for this grant early on, and I really was glad that that was the direction that was taken. And so we developed a work plan for the hospitals in this grant application process. Some hospitals adopted our work plan, some did not and had their own. But the beautiful thing was that after all the grants were given, and there were 10 grants given, and all of the different work plans were fired, and the hospitals began their work, all of the hospitals and some others, almost all of the hospitals, decided to work together in a collaborative, voluntarily. And we call it the Jumpstart Collaborative. And it was the first pure Michigan baby-friendly collaborative. There have been other collaboratives that Michigan has been a heavy participant in, including Best Fed Beginnings and Empower. But this is the first baby-friendly inspired collaborative in our state. And Margie and I are having a great time helping these hospitals with their quality improvement work. And our focus is to propel hospitals toward baby-friendly with supporting them in the implementation of baby-friendly practices with the eye on the prize, which is eventual baby-friendly accreditation. We're creating a quality improvement culture. So we're implementing safely with not just focusing on changing policy, but really dissecting the practices and understanding how to change process to make the practices effective, efficient, and safe. We are honoring the hospital's desire to educate their staff and to use messaging and materials that are compliant and that work. But our focus is not on having them necessarily complete the education. Remember, because this is called Jumpstart, so this isn't cross-country trip, right? It's also not evening stroll, right? So it's relatively fast-paced, but yet we know that it's just the introduction to a larger initiative. And so we really focus on teaching nurse leaders to motivate their staff, not just to check the box and get everyone through, but to introduce the training to the staff so that they want to do it, they want to start it, they understand why breastfeeding is important, they want to finish it, and then they want to practice what they learned. So we do a lot of work on motivation. And then we do a lot of collaborative work, and this was inspired by my experiences. I have done baby-friendly many different ways. I have done it in a silo on my own, It was lonely. I have done it in a small group with the hospitals in my system, and I have been part of large initiatives. And I definitely feel that doing it alone is not recommended, and that that I've enjoyed the collaborative relationship that I've had with other hospitals that have gone through the process with me. But we were not in a position to have a statewide baby-friendly collaborative yet. So we really took the best of a small group and made it a very intimate, and we're making it a very intimate activity. So we have monthly webinars, we have quality improvement activities, we have training opportunities, and we even have a little in-person meeting that we're planning. And we're really focusing on data collection, because quality improvement needs to be preceded by data collection, and it needs to be followed up with data collection. So we're really inspired. We're trying to inspire the hospitals to start to become habitual data collectors. There was an aha moment that I had. I was listening to a talk by Ann Muirwood, one of my mentors, in Boston, and she was up at the lectern, and she said, I was already in the baby-friendly pathway, and I thought I was pretty cool, and I was in Boston, and I thought I was doing it all. And she said, who is collecting data on skin-to-skin and all of these measures? And a lot of people in the room raised their hand, and I did not, because I was not collecting data yet. I wasn't to that, I wasn't to that stage yet, and I didn't think I had to be. And she said, Ann Muirwood said, it doesn't matter what stage of baby-friendly you're in. It doesn't matter if you're in the baby-friendly pathway. You need to be looking at your data. Start with 10 patients, 10 charts a month. And I looked at Bobby Phillip, my mentor who was sitting next to me, and I said, wow, Bobby, I got to start collecting data. And I haven't looked back. And I spend a lot of time now looking at data. So we really emphasize data collection, and it's part of the deliverable for this collaborative. We also acknowledge that quality improvement is not the language that we necessarily speak. So for this collaborative, we've created what we call the mountain climber system of quality improvement. And again, this was inspired by my experience with guiding and helping different hospitals in the state along their baby-friendly journey, as I had several hospitals that I would have monthly calls with just to support them in their efforts. We acknowledge that quality improvement is not easy, so that's why we use a mountain climber image. But we organize in 3 different categories, and this again was inspired by my monthly calls. We like to have hospitals think of something that they can do right away, that they can have success before the next call. So we call them quick wins. These are things like hanging a poster. These are things like writing a message on the whiteboard, which I call the billboard of the hospital room. Things that don't require pre-authorization, don't require administrative oversight, don't require any money, but really give the staff motivation to move forward. So we like hospitals to have 1 to 2 quick wins a month. But we are passionate about good quality improvement. So we do use the PDSA model. It helps us tackle complex issues, but it keeps it small, using the small test of change model. So we like to emphasize that we study these processes 1 nurse, 1 shift, 1 patient at a time. But we acknowledge that some programs don't fit in, some quality improvement changes require large-scale change. And we like to call these mountain projects. These are my favorite, and they really cannot be done by an individual. And this is one of the major messages of the Jumpstart Collaborative, is you need a task force. A task force is key. It is the antidote to apathy. It is the antidote to the fallout of leadership change. What happens when the director leaves? Does everything need to fall apart? Not if you have a 10-person task force. If 1 person leaves, you still have 9 people, right? It's the antidote to frustration, to isolation. How many times have we heard of a hospital trying to go through baby-friendly, and it's a lactation consultant that's trying to work on her own. It's not sustainable. So big mountain projects require a task force. So really to follow this plan, you have to have a task force. An example of a couple big mountain projects that we've done at St. John Hospital and Medical Center are discontinuing baby hats. We don't use baby hats anymore. More compliant with the new AAP safe sleep policies. We knew that the stockinette baby hats don't really keep anybody warm. So we're really changing the culture on baby hats, especially in my city of Detroit where we have so many sleep accidents, and they are a small but definite contributor to those in some cases. Donor milk on the term nursery. We're starting that in May. Rewriting some policies like hypoglycemia and bilirubin policies that need to be updated based on new criteria. Considering monitoring systems for the first hour to increase the safety of skin-to-skin. Assessments, nursing assessments such as the RAP assessment. These are all big mountain projects that require sign-off from chairs, money, and a lot of planning to do. So we like hospitals to always have one active mountain project. And we also, early on, acknowledge the importance of step 3 and step 10 in our collaborative, because I've made the mistake of saving those steps to the last minute. And that has inspired my work moving forward to put those steps in the beginning, 3, 10, connect. Start with those. So with step 10, we have created not only posters for the hospitals of Michigan to educate moms on the benefit of WIC, but also we educate staff using this handout which identifies things that staff members should know about WIC and they might not know, and also giving them something to give to every single patient. So they're not making judgments about who qualifies for WIC based on skin color, dress, but more are including everyone in the WIC decision. And finally, we're offering education for staff. This is a video that's being offered to all of the hospitals that in the state that is narrated by our own Julie Lothamer that is well designed to educate staff on nursing staff and providers on WIC training. So we're hoping that we are not just a dot on the map, but we are contributing to a movement and a change which will be seen in every corner of our state. Thank you very much. And I'd like to invite the other speakers up for some questions.
I'd like to know your reaction to a recent, in the last year to 2 years, magazine article in a parenting magazine about breastfeeding being connected to the increasing rates of non-vaccination, and how they said that it was not good to breastfeed because it led to non-vaccination. What's your reaction to that?
Well, I hate to comment without having read it because I'm wondering if that's exactly what it said. But I do not think breastfeeding contributes to rates of non-vaccination. Let me just say that. But it could be that certain people that might, and well, I hate to do something that sounds like a stereotyping somebody because I really hesitate to do that. But you know, I know some people that maybe chose to have a home birth and then they, of course, wanted to breastfeed, but they also had a belief that not to vaccinate, and sometimes that might be a package deal in one person. But No, I'm not aware of any connection between breastfeeding and the choice not to vaccinate. So anyway.
I think in my private practice, I have a lot of patients that seek out my office because of the breastfeeding expertise we have in the office. And they assume then, sometimes they assume that that we're going to be more tolerant or like encouraging of non-vaccination. But, you know, most of us in breastfeeding medicine are very pro-vaccine. So I think that at the provider level, we are not perpetuating that. So.
We were one of the pilots, so I just want to say thank you, Dr. Schreck, because after 3 years, the leaf flipped, and now we are being entertained by having the breastfeeding pericounselor being welcomed, allowed, and encouraged to be on the OB floor. And this was a hospital that did not want even Dr. Schreck's help to become breastfeeding friendly. So I just wanted to send it out to you and Ryan. Not to give up. I mean, you just do little inch by inch. And I thought, well, what changed? We didn't change other than we didn't go away. And I think it had to do with joint commission's perinatal standards, because that came up when Tina and I presented this last week to their staff. And a lot of the staff was really interested, but there will always be staff. The supervisor looked at the director of nursing and said, she can't possibly see everybody on the floor, can she? They'd have to only be WIC eligible, which of course was what they just rolled out to the hospitals, you know, WIC, the initiative part. So, and of course the director of nursing said, you know, and then she asked me, and I'm like, well, she's the one in charge, you know, the director of nursing, and she said, yeah, I think that's possible. So she's doing all the legalities. So just don't give up, because this was a real buck for a long time that Ryan Comfort was very familiar with.
Great, thank you.
And I would just add to, I mean, the amazing work that Dr. Schreck does, but, you know, just to anybody who's feeling that frustration, it's amazing sometimes what causes the change. And sometimes it's the CEO's wife having a baby. Sometimes it's the secretary having a baby and retelling their experience to someone else. Your champions will surprise you on where they emerge from, so be open to them and seize the moment when they arrive.
Like to know if is your crib card available someplace for the Can Do 5?
Yes, so if you didn't get to write down, you know, from the last slide, if you can download it from the website, I'm confident that Stacy Miller can get that to you. Yes.
Any other questions? Great, thank you very much.